Hello everyone, my name is David Lewis and I'm a fourth year medical student at TCMC. I'm going to be doing two lectures on how to read EKGs, and hopefully by the end of these two lectures you'll understand how and why EKGs work the way they do, and you'll understand the basics of how to read an EKG correctly. To give you a tiny bit of background on myself, like I said, I'm a fourth year medical student and I'm applying for internal medicine. I'm in the middle of my interviews right now. It's quite a daunting task, but it's fun and you'll enjoy it, and medical school goes extremely fast, so enjoy it while you can. Alright, so like I said, there's only a few learning objectives for this lecture. I want you guys to be able to understand the layout of an EKG and why things are placed the way they are. Let's see what else. To understand the different tachycardias and bradycardias, also known as tachyarrhythmias and bradyarrhythmias, and then some of the irregular rhythms like AFib. So I'm going to try to keep this as basic as possible. I remember being in your shoes and listening to the clinical lectures and not understanding a word of what was spoken. So I would suggest reading through the Dubin's EKG book at least twice if you really care about EKGs. It's more helpful than you might think. It's one of my favorite books, and I've taken a lot of the information that's in Dubin's and put it into this lecture. Alright, so let's get started. So the basics of an EKG, it can pretty much be broken down into a P wave, seen on the left, a QRS interval, and a T wave. And the P wave represents atrial depolarization, QRS is ventricular depolarization, and the T wave is repolarization of the ventricle. You may already know this stuff, but it's still important to hear again. With EKGs, the more you hear it and the more you see it and think about it, the more that they'll start to make sense. So you may be wondering, well, I see a T wave and that indicates ventricular repolarization, so where is atrial repolarization? That's somewhere between the P-PR segment. It's hidden in there, so the only thing you can really see is the depolarization part of atrial contraction. There's also a bunch of intervals that will become important when really kind of looking at different EKG pathologies, which we'll get to. So some of the numbers that I might say, like a PR interval should be between 120 to 200 milliseconds, isn't going to mean anything right now, but these numbers are extremely important, so I will say them because the more you hear it, the more they'll stick in your head. So the PR interval is from, as you can see, the beginning of the P wave to the beginning of the R wave. This shows it as being at the beginning of the Q wave, but 120 to 200 milliseconds. The QRS interval, which starts at the beginning of the Q wave and ends at the end of the S wave, should be under 120 milliseconds. And the QTC, which is a corrected QT interval, which every EKG will give you, should be under 440 milliseconds in males and under 460 milliseconds in females. One cardiologist gave me a good tip to remember this. Males, or I should say male, has 4 letters in it, so that's where you get the 40 from, and female has 6. Or you can just remember that female is a longer word than male, whatever works for you, but that will become important as you go along. The U wave I wouldn't really focus on too much right now. You can look up what that means, but I'm going to stick to the basics here. So when you zoom into a box, you see that there's some more smaller boxes, and I remember not wanting to remember these numbers also, but they are important, especially when looking at blocks, like AV blocks and stuff like that. So a big square is 0.2 seconds or 200 milliseconds, and a small square inside of that box is 0.04 seconds or 40 milliseconds, excuse me. So there's 5 of those small boxes in one big box. So 4 times 5 is how you would get to that 200 milliseconds, however, whatever units you want to use. And the vertical axis is the voltage and the amplitude. So a small box is 1, so that's easy to remember. And just like the horizontal axis, the vertical axis also has 5. So when you take 2 of those big boxes, that's 10 millimeters, and that's equal to 1 millivolt. So that's kind of irrelevant to this. But again, if you want to look up as to why that may be important voltage-wise, you can do that on your own time. The millimeters in height will become important when looking at things like left ventricular hypertrophy, but we'll get to that in the next lecture. So if someone hands you an EKG or you're going through a pile of EKGs, it's important to kind of understand what you're actually looking at. So before we get into what even a normal EKG will look like, I wanted to kind of break down the paper that you are holding in front of you and what each of the leads mean and where they are located. So on the left half of an EKG sheet, and this is of course if it's a 12-lead EKG, you're going to see the limb leads. So there's 3 regular limb leads called 1, 2, and 3 seen on the left going down, and then there's augmented limb leads, AVR, AVL, and AVF. The R stands for right, the L stands for left, and the F stands for foot. And I'm going to show you pictures of what exactly this means in a second. And then on the right hand side are the precordial leads, or the chest leads. So they start on the right sternal border and kind of wrap around towards the left armpit. So each one of these leads, the limb leads and the precordial leads, are like cameras looking at the heart. So each one is going to show you a different angle, and each one of these that you're looking at, take lead 1 for example, is the positive electrode. So I'm going to explain in a second that atrial depolarization in general will have a positive inflection when it moves towards a positive electrode. And before I get into that, I wanted to show another way of looking at an EKG, and that's kind of how can an EKG show the anatomy of the heart? Well, again, it's important to understand the lead placement and what view they're showing of the heart. So, and the next slide I'm going to show you pictures of this, but 1 and AVL are towards the left side of the body. They're placed on the left shoulder. So that shows, it would make sense that that would show the left lateral aspect of the heart. 2, 3, and AVF all have positive electrodes towards the apex of the heart. They're on the foot, on the left foot. So that'll show you the inferior aspect or the apex of the heart. And then some of the precordial leads like V1, 2, 3, 4 show the septum and the anterior aspect of the heart. And V5 and V6, like I said, which are on the left side of the heart, will also show the lateral aspect of the heart. And these leads, if you know the anatomy, also correspond to certain coronary arteries. So if someone has a heart attack, you can look at certain leads and know which vessel is involved. And this is obviously very important. So I tried to circle these the best as I could. So if you hear someone has an inferior infarct, then that doesn't necessarily tell the type of heart attack, but you will know right away that 2, 3 AVF are most likely involved. And then you can combine things to be inferior lateral infarct and so on. So it's important to kind of have these circles in your head as you look at an EKG. And here are the coronary arteries. At this point, I assume that everyone is done with anatomy. So the left coronary artery, also known as the left main, comes out of the left side of the aorta, which is kind of invisible, but you can picture it in the left picture between the left main and the right coronary artery. The left main splits into the left anterior descending, which you can see running down the anterior aspect of the heart. It runs in the interventricular septum on the anterior aspect. And then running around to the left is the left circumflex artery. And then off of the left circumflex, there are a variable number of obtuse marginal arteries. It can range from 1, 2, or 3, or more, I guess. Everyone's different as you've experienced in anatomy. And then coming out of the right side of the aorta is the right coronary artery, which branches into the right marginal artery, which kind of runs down the right aspect of the heart. And then you have the posterior interventricular artery, which most of the time comes off the right coronary artery, which is why you might hear a right dominant heart. That's explaining where the posterior descending, or the PDA, is coming from. And that runs to the apex of the heart. Okay, so let's talk about physics for just a second. So if you look at the simplified picture of the heart, and I labeled where the base and the apex is, the normal vector of depolarization is inferior and to the left. So when you sum up all the different magnitudes of electrical conduction, you get the arrow pointing down inferiorly and to the left. So keep that in mind as we go through each one of these leads. So these are the standard limb leads, 1, 2, and 3. So you see a negative and a positive. Each one of these limb leads has a negative and a positive electrode. And remember that depolarization is always going to go towards the positive electrode. So take lead 1, for example. The left arm, or the left shoulder, is going to kind of be your camera angle. So if you see an upward deflection in lead 1, that means that the electrical conduction is moving towards that lead. In lead 2, it's all the same thing. You're just placing the leads at different aspects of the body, and which allows you to see the heart from different views, like I am saying over and over again. So with lead 2, the positive electrode is now inferiorly on the left leg, and it's viewing the heart kind of from the bottom looking up. And lead 3 is the same thing. It's also positive on the left foot, looking up at the heart. So the augmented limb leads are AVR, L, and F. So these are similar in that they're on the limbs, but they're different in certain regards. So AVL and AVR, instead of the positive electrode now being on the foot, they're positive on the right and left shoulders, which are the opposite of the other leads that we just went over. So now, instead of saying that lead 2 is positive on the foot and negative on the right shoulder, now AVR is viewing it from the right shoulder. So if you look at a 12-lead EKG and you look at AVR, you're going to realize and see that the leads are recording negative or downward deflections. And this makes sense because if you remember the vector that I showed down and to the left, that's the complete opposite of where the positive electrode is. And AVF is the third augmented limb lead, and this is similar to 2 and 3, where you have a positive down on the foot. So 2, 3, and AVF, as long as depolarization is moving in that direction, which it should be, then that is also going to have an upward deflection because the lead is positive. And I know I'm repeating myself over and over, but it's really confusing, and until you hear it and say it over and over, it's going to continue to be confusing. Okay, so now for the precordial leads, which are V1 through V6, these show an anterior view of the heart, like I said, wrapping around from the right side of the sternum kind of over to the left axilla. And you can see a good example of where the leads are placed on the left and kind of where they are aiming at on the picture of the right. And notice that all of the angles are going straight towards where the AV node is. So when you put all of this together, it should hopefully begin to make sense that based off of where the leads are and where the positive lead is, that's why you see the positive or negative deflections. So like I kind of explained before with lead 1, where the positive electrode is on the left shoulder, you can see that the majority of the deflections, other than a little bit of that Q wave you can see, are all upward. And this is the opposite of AVR, which has a positive electrode on the right shoulder. So all of the deflections are negative because the depolarization of the heart is moving away from the left shoulder. So that should make sense, hopefully. And then if you look at the precordial leads, V1 through V6, you can tell that there's a change as you go from the right to the left side of the heart, meaning V1 towards V6. And this should also make sense because V1 is kind of looking more, excuse me, at the atria, and it's towards the right side of the heart, compared to V6, which is looking more towards the left ventricle. So what you see is a change in the R wave, and this is known as R wave progression. So when you see what is shown in this picture, you would say that's good R wave progression. And you can see that the strength of the R wave increases as you move left and laterally towards the left ventricle, which is where the depolarization is headed, right? Towards the left and inferiorly. Okay, so let's take a minute now and look at the conduction system of the heart. As you all know, you have an SA node and you have an AV node, and you have two bundles, the right and left bundles, also known as bundle branches, and those kind of lead to the terminal Purkinje fibers. But just to be a little more complicated, there are three internodal tracts, the anterior, middle, and posterior. Those are the tracks that the electrical conduction travels to go from the SA to the AV node. There's also what's known as Bachmann's bundle, which is just the track that goes to the left atria, because when atrial emptying of blood occurs towards the end, you have to have a little bit of kick and contraction to get the rest of the blood down to the ventricle. So it's important that there's electrical conduction to both of the atria. Now if you take a look at the left bundle branch, you can see, look at the right picture now, there's an anterior fascicle and a posterior fascicle. That just means branches. And that becomes important later on. In the second lecture, I'll talk about bundle branch blocks and how each one of these branches or fascicles can be blocked, causing different changes to the EKG and different consequences to the patient as well. So to give you a little bit of information about these areas of the heart that are important for conduction, the SA node is found between the SVC and the right atrial appendage. The important point is that the SA node paces physiologically at a rate of 60 to 100 beats per minute. So under 60 would be too slow, also known as bradycardia, and over 100 would be too fast, known as tachycardia. Another point which I'll explain in a different slide is something called overdrive suppression. And what that means is that the node or the area of the heart that is pacing will suppress any area of the heart below it that has the capability to pace. So we all know that the SA node normally in a healthy functioning patient and functioning heart suppresses everything below it, because we normally don't consider the AV node or one of the areas in the ventricle to pace, right? We normally think of the SA node as the area that paces. So all that is termed overdrive suppression. And another important point to think about is where the blood supply comes from. So for the SA node, normally it's in the RCA, and this is known as the SA nodal artery. And in the AV node, similarly, it's known as the AV nodal artery, and most of the time this comes from the RCA as well. So the AV node is found inferior to the SA node. It's between the coronary sinus and the tricuspid valve. This is known as the gatekeeper to ventricular conduction. And it's termed this because it has a long refractory period, which allows for filling of the ventricle. And as you know, that occurs during diastole. The bundle of His is just below the AV node. It goes in the membranous interventricular septum to the muscular septum, and then the bundle of His ends up dividing into the right and left bundle branches. And then the right and left bundle branches move further inferiorly to supply the right and left ventricles. And here's a picture showing all of that. You can try to match the numbers to the name. And I think I hit on everything else here. Okay, so let's get to how you actually read an EKG. The most important thing, like most in medicine, is to have an order that you like to use. So this is how I do it. You do not have to do it this way, but I will say that the first two steps kind of everyone does the same, which is the rate first and then the rhythm. The axis, looking at the different intervals, whether or not there are atrial or ventricular abnormalities like ventricular hypertrophy, if you see any ST changes like STEMIs, those can all kind of be variable as to whether or not you want to look for what when, but normally the rate and rhythm and the axis are kind of always performed first to give you an idea of what's going on with the patient and his or her heart. So the first thing I'm going to talk about is rate. And I kind of went into this before about overdrive suppression, so I'm not going to repeat myself. But what you want to look for, assuming you know what a normal P wave, QRS, and T wave look like, every time you look at the rate, you want to also kind of at the same time make sure you see or don't see P waves. So when you're looking at rate, the SA node normally paces at 60 to 100 beats per minute. If you see a rate of 60 to 80 beats per minute, that can also be from somewhere in the atria. But it's important to look at the P waves, because if the P waves look different, then they're not from the SA node. And I'm going to show you examples of this. But every place in the heart that has the ability to pace produces its own specific morphology. So in a normal sinus rhythm, the SA node produces a P wave that should look the same for every beat that you look at. If the P waves start to change, then you have to think maybe they're not all coming from the SA node, and I'll show you there is a term for that and a diagnosis for that. If you see a rate between 40 and 60, then you might want to think about it being from the AV node. And this is known as a junctional foci. And in this case, because you don't have a beat coming from the SA node or somewhere in the atria, there's no P waves, right? Because as we've gone over before, a P wave comes from the SA node or somewhere in the atria. So if you don't see a P wave, then something has to be going on. And the QRS duration is going to be under 120 milliseconds, which is normal. So as I said, those numbers that are a pain to memorize become extremely important, because if the QRS duration is greater than 120 milliseconds, then maybe something else is going on. And ventricular foci, meaning that you have cardiac pacing from somewhere in the ventricle, that is going to be 20 to 40 beats per minute. Now you're not going to see P waves, again for the same reasons I said, but now you're going to see a wide QRS, and this is because the conduction system in the ventricles is slower than it is in the atria. So whenever you see a prolonged QRS, a really wide QRS complex, think about either the conduction is being slowed somewhere more than it should be, or it's originating from the ventricle, somewhere in the ventricle. So the numbers are really important to remember. 60 to 100 is always going to be normal. Bradycardia is under 60. Tachycardia is over 100. If it's from the AV node, it's 40 to 60, and from the ventricle, it's going to be 20 to 40. So they kind of stepwise decrease, so that will help you remember them easier too. So now when you're calculating rate, it's not really necessary to do math or take out your calipers and try to calculate what's going on. The easiest way to do it is to look at the big blocks. And there is math behind it. Remember I said that it's 200 milliseconds for a big block and 0.04 seconds or 40 milliseconds for a small block. But the easiest way to do this is to look at how many big blocks occur between the R to R interval, meaning the two R wave peaks. And when you do this, you're also kind of subconsciously checking to see if the rate's regular or the rhythm is regular, because if the rhythm is regular, then the rate should be the same between all of the R to R intervals. So let's start looking at the picture from the bottom where it says 300. So that's one large block between every R to R interval. And the easiest way to do it is to find an R wave that starts on the bold line, or the beginning of a big box. So if you look at that interval and only see one large box between the two R waves, then obviously this patient's tachycardic. But if you calculate that out, it ends up being 300. If you look and you see two large blocks between, then it's 150. 3 would be 100. 4 would be 75. 5 would be 60. And 6 would be 50. So you'll get faster at this as you get some practice, but it's really, really important to remember 300, 150, 100, 75, 60, and 50. Write it down a few times, say it out loud a few times. It's pretty simple to memorize, and it will become extremely important as you begin to read EKGs and present EKGs to your attending physicians or doing rounds. Yeah, just memorize that. Okay, so here's a 12-lead EKG, and if you need some help remembering, you can go back and look at how I broke down a 12-lead EKG for what the leads mean. The one thing that I haven't shown on prior slides is the rhythm strip, which is the bottom line on the EKG is continuous. It's not separated by the other leads like the other three lines are. And you can see, I'm not sure if that's a 1 or a 2, but usually it's the second lead that is the rhythm strip. And you can use this to determine if the rate, you can use it to determine the rate by using the 300, 150, 100 method I just talked about. And you can also use the rhythm strip to determine if the rhythm is regular or irregular. So if you look at this, you can see that it's regular. Start the R wave on a big box, and you can say 300, 150, 100, 75, a little bit less than 75. So you don't have to be precise, but you would say this rate is about 70 to 75. but closer to 75. So again, look at each of the leads and say, okay, are they positive where they should be? Are they negative where they should be? If you look at the precordial leads V1 through V6, just for an example, the T waves should be positive, right? Because the deflection or the electrical depolarization is occurring towards the positive electrode. So if you see a downward T wave, that's called an inverted T wave, and that's an issue. So that's why this stuff is important. And you can just memorize what an inverted T wave looks like. But then if you look at AVR, you might freak out and say, oh my God, this patient has inverted T waves. But that's physiologic, right? Because AVR is kind of looking away from where the depolarization is going. So make sure this makes sense, because you don't really want to start learning pathology and disease until you understand what a normal EKG looks like. Okay, so on the topic of rate, I'm going to start with tachycardia, which is heart rate over 100. So the first thing you want to do is determine the location of pacing, meaning is the beat coming from somewhere above the ventricle, also known as supraventricular, or SVT, which is supraventricular tachycardia, or is it coming from the ventricle? And you can do this by looking at, are there P waves, which I talked about, and what is the duration of the QRS? Now, you can kind of go back and quiz yourself. What should the QRS complex duration be? It should be under 120 milliseconds. So I'm not going to go through each one of these, the steps, but step 2, so if it's narrow, meaning it's supraventricular, under 120 milliseconds, then here are some of the causes. It could just be a normal sinus tachycardia. There are atrial tachycardias, meaning that it's not from the SA node, but it's coming from somewhere in the atria. It could be AFib with RVR. So rapid ventricular rate just means that the person has AFib and is tachycardic. So if someone has AFib without RVR, then the rate's somewhere between 60 and 100. Atrial flutter, and then AVRT and AVNRT, which I'm not really going to talk about, but AVRT is one example of that would be Wolff-Parkinson-White. And step 3 is just if you see a wide QRS, meaning if it's over 120, now it's most likely from the ventricle. So ventricular tachycardia, ventricular fibrillation. Now these start to get really tricky because it can be an SVT, but if there's slowed conduction, also known as aberrant conduction, then it might trick you into thinking it's a ventricular origin, but it's actually from above the ventricle with slowed conduction. So I'm not going to go into that because it gets really tricky, and I'm going to try to keep this as basic as possible. Also, if you see a wide QRS, you want to look for pacing spikes because the patient might be healthy with a pacemaker placed, because pacemakers will have a wide QRS if it's ventricularly paced. If the patient has bradycardia, then the heart rate's under 60. Again, you want to determine where the pacing is occurring from. Is it from the SA node? Is it a junctional rhythm, right? Because the rate of that should be what? 40 to 60 beats per minute. Or is it ventricular? The rate of that will be 20 to 40. Again, check for P waves because that'll determine if it's sinus or junctional or ventricular. If it's sinus in origin, which most of the time it is, you could have a healthy patient who exercises, or there's a familial bradycardia, and in that case, ask for family history of, obviously a slow heart rate. You can ask if anyone has a pacemaker in the parents or the grandparents. Usually, you'll find that someone does. Sick sinus syndrome, which is an umbrella term for things like sinus pause, sinus arrest, tachybrady syndrome. It could be an idiojunctional rhythm, also known as just a junctional rhythm, kind of what I talked about before, and idioventricular. So I'm repeating myself. All right, so this is kind of like if you were looking at a telemetry monitor where it's just the rhythm strip. So if someone said, tell me what you're looking at, you would do the steps that I said before, right? You want to look at the rate and you want to look at the rhythm. You want to see, are there P waves? Are there QRS complexes less than 120 or greater? And are there T waves? Are there inverted T waves? And all the intervals. So if you look at this, I'll give you a second, or I guess you can just pause it. So this is normal sinus rhythm, right? The rate is between 60 and 100. It's kind of hard to see exactly where the box starts, but I would say it's about 75 beats per minute. It's a normal rhythm. You can, if you used calipers or you decided to check the 300, 150, 100 for each one of these, you would find that they're all the same. And the PR intervals, the QRS, and the QT all appear to be normal. One trick for looking at the QT interval, if the T wave is kind of in the middle of the R to R interval, then that means there's definite kind of prolongation of the QT interval. But as you see, the T wave is much closer to the associated QRS wave than the next one. So that's a quick way of saying that the QT interval is most likely normal. So what about this one? Remember, always do rate and rhythm first. So if you see the R wave starts, the second R wave you can see starts on a big line, so you would say 300, 150. It's a little less than 150, so maybe 125. 120, 125. Another thing you can do, you see those 3 tick marks below? From one to the next is 3 seconds. So this is showing a total of 6 seconds because you see the 3 tick marks. So if you count all of the QRS complexes and multiply that by 10, you're going to get the rate. And this is important if someone has AFib or some type of irregular rhythm. You can, if the EKG happens to have these tick marks, then you can just count them up and multiply by 10. And I did that for you. So this is just normal sinus tachycardia. It's a rate of 120. There are 12 of these, so multiply that by 10, you get 120 beats per minute. The rhythm is normal. There's P waves, so it's coming from above the ventricle. So this is normal sinus tachycardia. And I'm not going to go into causes of sinus tachycardia, but there's a huge list. Common ones like anemia, hyperthyroidism, anxiety, stress. All of those things can cause a sinus tachycardia. Also, the most common cause, or the most common finding on an EKG for someone with a pulmonary embolism is sinus tachycardia, not that S1, Q3, T3 that you kind of learn about. Okay, so what's the diagnosis for this rhythm strip? Now, the first thing that hopefully you observe is that there's no P wave, and the rhythm appears normal. So what you would want to do is say, okay, there's no P wave, what's the QRS? If you look from the beginning of, there's no real Q wave, so the upslope of the R wave to the end of the S wave, there's 3 small boxes. So 4 times 3 is 12, so if you use the right units, it's 120 milliseconds. So as you know, less than 120 is okay. So this is, close to being prolonged, but you would say this is normal. And the T waves appear normal. As I said before, the T wave is nowhere close to being in the middle of these two. And of course you want to look at the rate, so 300, 150, 100, 75, 60, 50. So this is slow. There's no P waves, normal QRS, normal T waves. So if pause it, try to think of what the diagnosis is. So this is what a junctional rhythm looks like. As I said, no P waves, normal QRS duration. The rate's about 50. Junctional rhythm, as you now know, is between 40 and 60, so that should make complete sense. Now, what if there was a P wave? Well, then it would just be sinus bradycardia, assuming that everything else was normal. Oh, I forgot to hide the answer. So this one, again, no P waves. It's obviously bradycardic. Again, there's the, the 3 tick marks above. So all you have to do is say, okay, I see 3 QRS complexes, multiply that by 10 to get your 30. There's no P waves. The QRS now is greater than 120. If you want to calculate to see what it is, go ahead and do that. You now know kind of the numbers involved for the small boxes and the big boxes. But you can see that the QRS is definitely widened over 120. There's no P waves. Everything else is regular. So this is an idioventricular rhythm. So what about this one? Pause it, see if you can figure what's going on here. Don't get intimidated when you see an EKG that looks like this, because now you're beginning to have the tools to diagnose what's going on. So I always like to look at the rhythm strip first. You can calculate the rhythm. There's definitely more than 4 or 5 boxes between each one, so this is a bradycardia of some sort. There's no P waves. QRS is widened. So based on that, you would say, okay, this is probably an idioventricular rhythm. But then you also might fight with yourself, say this is on a test, and say, okay, well, normally an idioventricular rhythm should be between 20 and 40, so this is not 40 beats per minute, so what's going on? Well, this is a little tricky, but this is known as an accelerated idioventricular rhythm. So the jargon kind of gets a little complicated and numerous, but so a normal idioventricular rhythm is 20 to 40. An accelerated idioventricular rhythm is going to be above 40, like a normal rate 60 to 100. If you see this, but it's over 100, the patient would be considered to be in ventricular tachycardia, or VTAC. So that's a problem. And what else? So you can see a few normal heartbeats in between the idioventricular rhythm on the rhythm strip. So if you look at the second beat, you see the T wave, and then you kind of see a little blip, which may or may not be a P wave. Most likely it's not. So what you're going to think is that something is going on in the SA node. And you can see this at the very beginning of the rhythm strip also. That you see the T wave, and then you don't see anything. Excuse me, you don't see anything, and then you start seeing this ventricular rhythm. So what that means is this patient probably has some type of sinus node dysfunction. And now if you remember back to the overdrive suppression, now everything else below the SA node is failing, and the ventricle kicks in and starts pacing itself. So I kind of wrote this is common after an acute MI. If someone has a sinus node dysfunction, or if someone has sinus bradycardia, that you might end up getting these ventricular rhythms. So an EKG is a glimpse at a patient, but you want to look at the patient also, because that's obviously the patient's more important than what an EKG might show. Okay, so what is going on with this? So now all you see are big, wide QRS complexes. You obviously don't see any P waves or T waves. If you look at the R waves, you can kind of see that this is definitely severely tachycardic, widened QRSs. So this patient is now in ventricular tachycardia. This is definitely over 30 seconds. So if it's under 30 seconds, then you would say this is non-sustained VTach. If it's over 30 seconds, then it's sustained. Also, the heights of each one of these QRS complexes are identical. So it would be a monomorphic ventricular tachycardia. So VTach used to confuse me a lot, so I figured I would put in all of the different possibilities so you will not get confused on a test or in real life. So I just showed you monomorphic before, so take a look of the three that I showed, and hopefully now you can already point out that monomorphic would be the second picture I showed. But let me go through some of the points above. So polymorphic ventricular tachycardia is just a form of ventricular tachycardia with multiple ventricular foci, leading to varying QRS morphology. So this is similar to how I said that you always want to check P waves, because P waves can vary, right? And that would be because they are originating from different locations. So polymorphic VTach is similar to that. And then there's something called torsades, which is commonly tested. And that is a subtype of polymorphic ventricular tachycardia, and that's associated with prolonged QT intervals. So if someone has a severely prolonged QT interval, it might start out as a regular rhythm with a prolonged QT, but that can develop into torsades. So it's important to figure out arrest, Tachy-Brady syndrome. It could be an idiojunctional rhythm, also known as just a junctional rhythm, kind of what I talked about before, and idioventricular. So I'm repeating myself. All right, so this is kind of like if you were looking at a telemetry monitor where it's just the rhythm strip. So if someone said, tell me what you're looking at, you would do the steps that I said before, right? You want to look at the rate and you want to look at the rhythm. You want to see, are there P waves? Are there QRS complexes less than 120 or greater? And are there T waves? Are there inverted T waves? And all the intervals. So if you look at this, I'll give you a second. Or I guess you can just pause it. So this is normal sinus rhythm, right? The rate is between 60 and 100. It's kind of hard to see exactly where the box starts. But I would say it's about 75 beats per minute. It's a normal rhythm. You can, if you used calipers or you decided to check the 300, 150, 100 for each one of these, you would find that they're all the same. And the PR intervals, the QRS, and the QT all appear to be normal. One trick for looking at the QT interval, if the T wave is kind of in the middle of the R to R interval, then that means there's definite kind of prolongation of the QT interval. But as you see, the T wave is much closer to the associated QRS wave than the next one. So that's a quick way of saying that the QT interval is most likely normal. So what about this one? Remember, always do rate and rhythm first. So if you see the R wave starts, the second R wave you can see starts on a big line, so you would say 300, 150. It's a little less than 150, so maybe 125. 120, 125. Another thing you can do, you see those 3 tick marks below? From one to the next is 3 seconds. So this is showing a total of 6 seconds because you see the 3 tick marks. So if you count all of the QRS complexes and multiply that by 10, you're going to get the rate. And this is important if someone has AFib or some type of irregular rhythm. You can, if the EKG happens to have these tick marks, then then you can just count them up and multiply by 10. And I did that for you. So this is just normal sinus tachycardia. It's a rate of 120. There are 12 of these, so multiply that by 10, you get 120 beats per minute. The rhythm is normal. There's P waves, so it's coming from above the ventricle. So this is normal sinus tachycardia. And I'm not going to go into causes of sinus tachycardia, but there's a huge list. Common ones like anemia, hyperthyroidism, anxiety, stress. All of those things can cause a sinus tachycardia. Also, the most common cause, or the most common finding on an EKG for someone with a pulmonary embolism is sinus tachycardia, not that S1, Q3, T3 that you kind of learn about. Okay, so what's the diagnosis for this rhythm strip? Now, the first thing that hopefully you observe is that there's no P wave, and the rhythm appears normal. So what you would want to do is say, okay, there's no P wave, what's the QRS? If you look from the beginning of, there's no real Q wave, so the upslope of the R wave to the end of the S wave, there's 3 small boxes. So 4 times 3 is 12, so if you use the right units, it's 120 milliseconds. So as you know, less than 120 is okay. So this is, close to being prolonged, but you would say this is normal. And the T waves appear normal. As I said before, the T wave is nowhere close to being in the middle of these two. And of course you want to look at the rate, so 300, 150, 100, 75, 60, 50. So this is slow. There's no P waves, normal QRS, normal T waves. So if pause it, try to think of what the diagnosis is. So this is what a junctional rhythm looks like. As I said, no P waves, normal QRS duration, the rate's about 50. Junctional rhythm, as you now know, is between 40 and 60, so that should make complete sense. Now, what if there was a P wave? Well, then it would just be sinus bradycardia, assuming that everything else was normal. I forgot to hide the answer. So this one, again, no P waves. It's obviously bradycardic. Again, there's the the 3 tick marks above. So all you have to do is say, okay, I see 3 QRS complexes, multiply that by 10 to get your 30. There's no P waves. The QRS now is greater than 120. If you want to calculate to see what it is, go ahead and do that. You now know kind of the numbers involved for the small boxes and the big boxes. But you can see that the QRS is definitely widened over 120. There's no P waves. Everything else is regular. So this is an idioventricular rhythm. So what about this one? Pause it, see if you can figure what's going on here. Don't get intimidated when you see an EKG that looks like this, because now you're beginning to have the tools to diagnose what's going on. So I always like to look at the rhythm strip first. You can calculate the rhythm. There's definitely more than 4 or 5 boxes between each one, so this is a bradycardia of some sort. There's no P waves. QRS is widened. So based on that, you would say, okay, this is probably an idioventricular rhythm. But then you also might fight with yourself, say this is on a test, and say, okay, well, normally an idioventricular rhythm should be between 20 and 40, so this is not 40 beats per minute, so what's going on? Well, this is a little tricky, but this is known as an accelerated idioventricular rhythm. So the jargon kind of gets a little complicated and numerous, but so a normal idioventricular rhythm is 20 to 40. An accelerated idioventricular rhythm is going to be above 40, like a normal rate, 60 to 100. If you see this, but it's over 100, this the patient would be considered to be in ventricular tachycardia, or VTach. So that's a problem. And what else? So you can see a few normal heartbeats in between the idioventricular rhythm on the rhythm strip. So if you look at the second beat, you see the T wave, and then you kind of see a little blip, which may or may not be a P wave. Most likely it's not. So what you're going to think is that something is going on in the SA node. And you can see this at the very beginning of the rhythm strip also. That you see the T wave, and then you don't see anything. Excuse me, you don't see anything, and then you start seeing this ventricular rhythm. So what that means is this patient probably has some type of sinus node dysfunction. And now if you remember back to the overdrive suppression, now everything else below the SA node is failing, and the ventricle kicks in and starts pacing itself. So I kind of wrote this is common after an acute MI. If someone has a sinus node dysfunction, or if someone has sinus bradycardia, that you might end up getting these ventricular rhythms. So an EKG is a glimpse at a patient, but you want to look at the patient also, because that's obviously the patient's more important than what an EKG might show. Okay, so what is going on with this? So now all you see are big, wide QRS complexes. You obviously don't see any P waves or T waves. If you look at the R waves, you can kind of see that this is definitely severely tachycardic, widened QRSs. So this patient is now in ventricular tachycardia. This is definitely over 30 seconds. So if it's under 30 seconds, then you would say this is non-sustained VTach. If it's over 30 seconds, then it's sustained. Also, the heights of each one of these QRS complexes are identical. So it would be a monomorphic ventricular tachycardia. So VTach used to confuse me a lot, so I figured I would put in all of the different possibilities so you will not get confused on a test or in real life. So I just showed you monomorphic before, so take a look of the three that I showed, and hopefully now you can already point out that monomorphic would be the second picture I showed. But let me go through some of the points above. So polymorphic ventricular tachycardia is just a form of ventricular tachycardia with multiple ventricular foci, leading to varying QRS morphology. So this is similar to how I said that you always want to check P waves, because P waves can vary, right? And that would be because they are originating from different locations. So polymorphic VTach is similar to that. And then there's something called torsades, which is commonly tested. And that is a subtype of polymorphic ventricular tachycardia, and that's associated with prolonged QT intervals. So if someone has a severely prolonged QT interval, it might start out as a regular rhythm with a prolonged QT, but that can develop into torsades. So it's important to figure out the cause of their prolonged QT. So the first image is showing the torsades. And you can see it's polymorphic because unlike the second one, they have different heights. And you can also see that they kind of twist around a central point. The apex increases, then it decreases, then it increases again. So that's very pathognomonic for torsades. Then you have monomorphic VT. All the heights are the same. They look the same. And then polymorphic VT from any cause. Looks similar to monomorphic, but you can see that the heights are a little bit different. The widths are a little bit different. So you also want to compare these to ventricular fibrillation because that can kind of get confusing too. But these are pretty common pictures for what the three of these will look like. So now I want to talk about rhythm. So you look at the EKG, you calculate the rate, then you look at the rhythm, and you say, well, the rate between one R to R interval is not the same as the second R to R interval. So that means that there's an irregular rhythm going on. So again, step one, look at the P waves. Are there P waves? If there is, then it might be just be a sinus arrhythmia. You might have a PAC or wandering atrial pacemaker, multifocal atrial tachycardia, which I'll explain all these, AFib, or aflutter, I shouldn't say AFib, and certain types of AV blocks. If you don't see a P wave, it might be a PVC, it might be atrial fibrillation, it might be ventricular fibrillation. And then step two, you want to see is it narrow or wide, because that'll help to determine the location of the origin. So sometimes when you pick up an EKG, everything will look normal, and on the top, the EKG machine will read this as a sinus arrhythmia, and you're going to say, what exactly does that mean? Well, that's normal. It's physiologic. It's a very slight irregularity in the rhythm due to changes in vagal tone during inspiration and expiration. So when you inhale, parasympathetic tone decreases, which increases the heart rate, and vice versa. And here's a nice picture showing that, especially on the bottom, that during expiration, heart rate slows down, becomes a little more bradycardic, and during inspiration, the heart rate increases. Now, it's not always going to be that dramatic. It could be very, very slight. It's not in everyone. The EKG won't always pick it up. But it's a good thing to know. So if someone says, this is sinus arrhythmia, what do you want to do? Well, you're going to say nothing because the patient's just breathing. So what about this? Now, I kind of gave you a hint because we're in the irregular rhythm section. But you can tell just by looking at this that there's an irregular rhythm of some kind going on. So what you want to do, you can calculate the rate. You see the 3 tick marks above. If you if you add up the R waves, you see 1, 2, 3, 4, 5, 6, 7, 8, 9. So 9 times 10 is about 90 beats per minute. You know it's irregular, so you want to check for P waves, and you in fact see P waves before each one. So you can't have AFib, right, because there are P waves. Now, you also want to check to see if the P waves are morphologically identical. And you can do that, but I'll also say, because I know the answer already, that if you look, you might notice that most of the R to R intervals are identical. There's one that happens to be a little shorter than the other. And you might also notice, if you look closely, that the P wave is smaller and not identical to the other P waves. So that gives you the diagnosis of a premature atrial contraction. And that just means that there's an ectopic area in the atria somewhere that is irritated and shoots off a beat. So that kind of overpowers the SA node, and you get an extra beat really quick. So when people say, sometimes they feel extra beats, this is one of those extra beats that the patient might feel. Otherwise, everything else is normal, right? The P wave's abnormal compared to the other ones, but there's still a P wave. Excuse me. The QR restoration's okay. The T waves are inverted, so that's an issue, but we don't know what lead this is in, and there could be some underlying pathology. But for now, let's ignore that. And we already went over the rate. So one thing I will say to make this a little more clinical is that sometimes you might feel a pulse and think that the patient's in AFib because of an irregular rhythm. But pay close attention because AFib, like, excuse me again, I'll talk about is irregularly irregular. This, if someone has a normal pulse and every once in a while it seems irregular or the beat occurs a little quicker, then it's most likely just a PAC or a premature ventricular contraction, a PVC. So you can't always diagnose someone with AFib just by, telling your attending, oh, this person has AFib, everything's irregular. The more detailed you are with this observation, the better you'll look. But an EKG would still be indicated to determine maybe this patient actually does have AFib. So, but for now, just if you can look at that EKG and see why it's a PAC, then you're on the right track. Now, what about this? Everything, again, is the same, except you have this, what I would call that a wide, enlarged QRS complex compared to everything else. The other thing you'll notice that there's no P wave in front of it, so it's just this wide QRS complex that occurs faster than the normal PQRST heartbeat does. So this is what's known as a PVC. And this should make sense, right? Because it's from the ventricle, so there's no P wave. Ventricular conduction is slow, so that's why you see this wide QRS complex. And we already talked about ventricular tachycardia, but one thing I didn't say, I already talked about sustained, non-sustained. But VTAC is just 3 or more PVCs. So that's a cool thing to note, that if you see one of these, that it's a PVC, but if you start to see a bunch in a row, then you might have to start worrying about ventricular tachycardia. Okay, now I want to talk about AFib, because a lot of patients that you'll see during your clinical years, maybe during your first and second years with your preceptors, you've already seen this. But AFib is a replacement of coordinated atrial electrical activity by disorganized and extremely rapid, repetitive atrial excitation. So the thought is that you have these micro reentrant circuits that kind of just lead to this irregular conduction down to the AV node, which then filters out what it wants to send down to the ventricles. So because of that, the AV node kind of slows the beat down that's coming from the atria down to 150 to 180 beats per minute. And I got this picture from this review article in Nature. It's about the drug therapy, but it was a good picture showing kind of what's going on. So this is what AFib looks like. Now, if you look closely, like I said, I always look at the second lead, which is the rhythm strip on the bottom. You can see this is definitely irregularly irregular. It's not just one PVC or PAC that's making it look irregular. There's no P waves, but the QRS and the T waves all appear normal. If you calculate the rate, then you'll see that it's normal. It's between a 60 and 100. So I already kind of mentioned what the diagnosis would be earlier. It's AFib, but without RVR. There's no rapid, no rapid ventricular rate. And you can also pause this and kind of look through all the other leads to see how's the R wave progression, is anything else going on. And actually, speaking of that, if you look at this, the R wave progression is pretty terrible from V1 to V6. I'm sure you could pick up a few other things on this as well. What about this one? So again, this is irregularly irregular, no P waves. QRS is normal duration. So this would be AFib with RVR, because most of the intervals are around 150. And if you remember, we said most of these rates are, 150 to 180. So that would make sense. Okay, atrial flutter, similar to AFib, but different in the sense that it's a single atrial automaticity focus instead of it being multiple areas in the atria like AFib was. So in this case, the rate's about 300. Again, the AV node filters it out to a rate normally about 150. And the most common thing you'll see on exams is this sawtooth pattern. And what this indicates, the sawtooth pattern, in reality is how many P-wave initiations there are for every QRS complex. So for every atrial beat that this ectopic area produces, how many have to occur before the AV node lets one through. So typically this is known as a block, and there's a ratio of the P waves to the QRS. So in this case, in the picture on the right, this is a 4-to-1 block because most of the time, this really should be a variable block, but most of the time if you count the P waves, you see 4 to every 1 QRS. So that's why it's 4-to-1. The other thing, unlike AFib, you're going to see P waves, right? Because that's what creates the sawtooth pattern. Now, it's not always 4-to-1. Like I said, it could be variable. In this case, I'm showing, excuse me, 2-to-1 atrial flutter. And I'm showing that because, look at the rhythm strip, you can count that for every 1 QRS, there's about 2 P waves. It's a little harder to see. And I put that in here because 2-to-1 flutter can appear similar to SVT, where you're not sure what's a T wave, what's a P wave. So this SVT that I talked about earlier, which is, to refresh your memory, supraventricular tachycardia, you can, and I put a list of what the rhythms included under SVT are. You can use vagal maneuvers like a carotid massage or Valsalva to increase the refractoriness of the AV node. So that will allow for more flutter waves to be revealed. And there's a great example on page 160 in the Dubin's Orange EKG book. So take a look at that. There's an actual example showing before and after 2-to-1 AF flutter. So wandering pacemaker and multifocal atrial tachycardia. For some reason, these are some of my favorite rhythms. You don't see them that often, but both of these, the diagnosis is dependent on the rate. So if it's a normal rate, 60 to 100, it's known as wandering pacemaker. If it's over 100 and tachycardic, then it's multifocal atrial tachycardia, or MAT. So if you have 3 or more dominant pacemakers in the atria, they kind of migrate from one to the other, so you get these variable P waves. And like I said, each P wave is distinct based on where it's coming from. So if you see an irregular rhythm with P waves, again, you know it's not AFib. Again, you want to make sure it's not something like a PAC where the P wave is also different. But if you see 3 or more different P waves, and based on the rate, you can make the diagnosis of wandering pacemaker or MAT. So if you look at the picture, look at each P wave, and they do a good job of showing that some are upright, some are smaller, some are inverted, some are bifid or notched. That's the very last one. Yeah, and MAT is also associated with pulmonary disease. Not really sure why that is, but that's a great test question that you'll see on step 1 and step 2 that it's associated with things like COPD. And lastly, I'm going to talk about ventricular fibrillation, which is similar to AFib, no P waves. It's coming from the ventricle, so they're wide QRS complexes. They're fibrillating, and the EKG literally looks like they're fibrillating. VTAC commonly turns into VFib. So it's important to treat ventricular tachycardia. In ventricular fibrillation, you treat with an unsynchronized cardioversion, meaning you shock the patient. Unsynchronized means that the machine, the defibrillator, does not sync to the R waves because there's no R waves to sync. If someone's in ventricular tachycardia, then it's synchronized cardioversion. So that's another good test question and also important for saving lives. Okay, so what is going on here? This is kind of tricky, and it's more just meant to be a learning point that you see something's going on the left side of this telemetry strip. There's some type of tachycardia, right? You know just by looking at it that the rate's about 150. And then they say that verapamil is given. Verapamil is a non-DHP calcium channel blocker. And then something happens after they give verapamil. And what happens is this person goes into ventricular flutter, which is a fast type of VFib. And then the patient, from there, like I said, commonly VFib, the person goes into VTAC, which is the ventricular flutter is a type of VTAC. And that develops into ventricular fibrillation, as you can see by the progression of this. So what might be going on? Why would someone who has an SVT, who's given a calcium channel blocker, end up going into VFib? And, well, let's see, because I wrote a question below. Calcium channel blockers should not be used to manage which condition? Atrial fibrillation, AV reentrant tachycardia, which is a type of SVT, Raynaud's, and essential hypertension. Well, I kind of just gave it on because I said that AVRT is a type of SVT, and that is the answer. AVRT includes Wolff-Parkinson-White disease, which is due to an accessory pathway. So if you give a calcium channel blocker to someone with WPW, then you block the AV node and you allow for further conduction through the accessory pathway. In WPW, the accessory pathway is known as the bundle of Kent. So remember that, that's important. Sometimes beta blockers are used for Wolff-Parkinson-White, but you never want to use something that inhibits the AV node, like a calcium channel blocker or digoxin. So I know that's a lot. I hope I did a relatively good job of hitting the major points for this lecture. Feel free to review this at your own pace. Try to go through the key points that I wrote down and see if you can understand them, if you think you can read these similar EKGs on your own. There's a lot of websites online where you can quiz yourself. It takes a while. I'm still learning how to do this also. I am by no means a cardiologist, but I do have fun doing this. If you have any questions about the content or you're curious about becoming a cardiologist, which is what I want to do, feel free to ask me. There's my name and my email address. And the next lecture is going to be on determining the axis of an EKG. Are there ischemic changes like ST depression or ST elevation, Q waves, AV and bundle branch blocks, and then quickly atrial and ventricular abnormalities. Thank you.